Hello, Calaveras County, and welcome to another edition of Mondo Calaveras, where we learn a lot more about the county in which we live. Now, today, folks, we're kind of keeping with our sort of health theme that we've had for the past couple of editions. We've got with us Dr. William Griffin, who is the head of the Diagnostic Imaging Department at Mark Twain Medical Center. Thank you for joining us, Dr.
Thank you.
Griffin.
You're welcome.
Now, how does one become a radiologist? What kind of inspired you and got you into it?
Where do we begin? Basically, I wanted to be a physician since I was 7 years old.
Oh,
Never
okay.
changed. But anyway, to make a short story long, it's just, 4 years of college, 4 years of medical school, internship, 4 years of residency, and then you're ready to go to work.
And to do that in radiology, do you immediately specialize because that's such a specific field, or do you go through kind of as being a general physician and then maybe during your internship or something do you specialize?
Well, you specialize afterwards, but
You do?
everybody
Okay.
decides when and where.
I
mean,
see.
I was in the Navy for 5 years in between finishing my medical school and internship,
Oh,
and
okay.
then going into radiology. So I had 5 years of being a physician, on
Okay.
the outside. And then then a radiology residency, and then you just dive in.
Dive in.
Dive in. I've been doing this actually as a radiologist since 1969.
Wow. And how much of that has been here in Calaveras County?
Since 1989.
1989, okay.
So I spent 20 years on the East Coast teaching in New York City and working, and then decided to get a taste of the good life.
That's right. Welcome to Calaveras
Came
County.
to Calaveras County. When I first encountered with Calaveras County in 1988, when I was invited to come out and look around, I didn't believe there was any place in the world that was still like this.
It is something
It's different
to see, isn't
it's
it?
awesome, and
Yeah.
it took me one weekend. I went back east. I notified my partners I was resigning. I gave them 6 months notice, and here I am.
Off you went.
Off I went.
Well, we're glad to have you. So you've seen a lot of the growth that Mark Twain, St. Joseph's Hospital, Mark Twain Medical Center, Mark Twain Hospital has seen over the years. When you got here, I can't remember when the new hospital was actually built. Was that built yet?
No, when I
it
got here, we
wasn't.
still had the little hospital.
Still had the little, okay.
And that we were in that actually for 10 years before we actually had the.
I was
it
trying
was
to remember
almost.
the year.
I think it was 2000 when the new hospital was actually finished. So, we had and it was really modified. I mean, if you think about it, we had, other than we had basic X-ray in the old hospital, and we had vans for everything else.
That's right. All the trucks pulled up to
That's
the
right. We had
side.
nuclear medicine in a van and CT scanning in a van. Of course, MRI wasn't even available at that time.
That's right.
So that's true.
And so what, maybe from, let's say I break my arm and I come into the emergency room, what's going to happen? And then when do you get involved as the radiologist? Because I know what they'll do is wheel me into the room, and that's usually kind of you tell me the term, but I would call them an attendant kind of thing.
The emergency room physician. First the nurse and the emergency physician takes an analysis of what he thinks is going on. If you got a fracture, he orders an X-ray. Because everything is now digitized, as soon as the technician takes your X-ray, it's on a screen.
Oh.
It's on a screen in my office, or if it happens to be after hours, it's on a screen in my study at home, instantaneously.
Oh my gosh, okay.
So there's no time delay. It's there.
Yeah.
So that's it. And then I just look at the films, call the ER doc, tell them yay or nay, and it goes from there.
And so you're the radiologist, and that is what your
Correct.
doctor's called, making sure. You deal all with those kinds of images and scans that we get, correct?
Correct.
You don't actually provide a treatment, or do you?
No.
For anything? Okay.
Not really. No, not anymore.
It's mostly diagnostic,
basically,
right?
yeah.
Okay.
Just to clarify, there is a point in time when after your training, you can go you can do both diagnostic and therapy, or you can split.
Okay.
And in about 1975, it became obvious that the changes in diagnosis were so tremendous that you just couldn't do both. And so I stuck with diagnostic and left out the therapy.
Now, so at Mark Twain, what do we have? Sort of the whole shebang now? Do we have every kind of scan that you could need to get, or do we still have a trailer coming up for maybe the most sophisticated? Or
Well, we have, let's put it this way, almost everything, okay? Basic x-rays are there, and fluoroscopy, and nuclear medicine is there. MRI is there now as a fixed unit. CT scanning is there as a fixed unit. The only thing we don't have that comes in a van is PET scanning.
Okay, and what's PET
And PET scanning is a nuclear imaging that uses a positron, or positive charged particle, instead of the usual nuclear medicine, which uses all negatively charged particles.
Oh, okay, I didn't realize that.
And the reason it's different is because it's based on physiology. So positively charged nuclear particles go to actively metabolic areas.
Oh, okay.
So if you have tumor, which is probably the most metabolically active thing you can have in your body, then it will have an affinity for taking up this isotope. So the vans, they administer the isotope, do the pictures. They also do a CT scan, and then they fuse the images. So that you see a set of images here that says, okay, here is the actual increased activity or the abnormal spots. You can either look at it and guess and say, oh yeah, that's in X, Y, or Z. Over here is a scan that shows you everything to precisely in the inside of your body. The computer puts them together, and the fused image shows you not only where the malignancy is or the increased activity is, but in exactly what organ it is and where it is in the body.
Wow.
And you can manipulate the data in almost any way you want to. So it's an absolutely incredible piece of equipment.
And as you were describing that, I thought about it, and I'm 50 years old, so I've gone from television to computer. That's not quite radio. My father just marveled at going from the radio to the television to the computer and that. But in diagnostic imaging, I can imagine that the computer has just been something incredible.
It is. The computer is amazing. When I started in radiology, my first residency program, we were still using a field unit from the Second World War in one of our rooms. Like the cartoons where the radiologist on one side and the patient's on the other, and you look through a screen. So that's how I started.
Wow.
From then to just improvements in imaging tubes and the strength of the tubes and how long they would last. And then computers came along. And you're right. First it was simple CT. I don't know if you're aware of this, but the first CT scans were head CTs, and they were developed by a company called EMI, and that company was owned by the Beatles.
Oh, yeah, okay.
And funded by the Beatles. And so the first CTs came out of England from EMI.
I'll be darned.
And then, of course, everybody got in the game. So now, as we've progressed in time, scanners have gotten faster and better and faster and better. And as where we're at now is we've sort of reached the point where the rate at which a CT scan spins and the detectors pick up the imaging is, in my opinion, is getting close to its max.
Okay.
But what's happened is the computers have jumped ahead of that. And so now you can spin a computer at the same rate, let's say you did 2 years ago. However, the computer is now able to take that data and expand it to the point where, for instance, if we said 4 years ago we were getting the equivalent of 8 slices a minute through your body, or 8 slices a second, through your body, we are now at 128 slices.
Oh my gosh.
Now, that's not all happening with a faster spin. It's happening with a somewhat faster spin, more detectors, and incredible computers that are doing like 300,000 calculations for every 0.75 millimeter cube of tissue.
Oh my gosh.
And it does it instantaneously.
Yeah.
So the computers are really
pretty incredible.
Yeah, it is. The computers are amazing.
Now, do you see when you're looking at and actually maybe help me out a little bit? So you've got X-ray, which is a little bit of radiation that shows us what our bones look like, and then you get to the CT scan, which shows what?
Well, the CT scan, fortunately, because of the differential equations, will differentiate between soft tissues, water density soft tissues, which are solid organs, hair, and bone. Okay.
I see.
And because it just accumulates the data, and because you're working with the computer, you can selectively say to the screen, I want to look at this person's bones. So now what you're looking at on the screen is a skeleton. Okay. And you can see the detail of the bones if you're looking for fractures or whatever. Or you can say, person has a pneumonia. So I don't want to see the bones, I want to see the lungs.
See the lungs.
So now you see the lungs, again, by just changing the parameters. And that's really that's the sort of the key factor in CT scanning. It allows you to use a certain amount of radiation, accumulate a huge amount of information, and then selectively decide what part of it you want to look at.
Does the one scan provide all that data? So then you could, I mean, if suddenly you decided you wanted to look at the bones from that same scan, or does the person have to come back into the scan?
It's all done.
It's all in there in that
and
one.
And the amazing thing now with a 128 slice scanner, if I needed to, I could scan from the top of your head to the bottom of your pelvis in 17 seconds.
Wow.
Okay. And at the end of that time, I would have a picture of you, okay, on the inside. And then selectively, I can look at the brain, I can look at the bone around the brain, I can look at the facial bones, I can look at the orbits, I can look at the neck, chest, abdomen, and each one has a different set of parameters. And so the detail is created differently by using all these different parameters with a computer.
Okay. So, now, are the slices basically this way, you know, kind of through our bodies? They're not, so you're not kind of looking at a big person standing there, you're looking at sort of a slice like if you were to cut a tree and look at the rings, right?
Like we use it like a slice of bread.
Okay.
You know, the initial scanners were strictly loaf of bread. You know, and they were always oriented toward from bottom to top. And what you looked at was one slice after the other. And mentally, you build this image of what this is going to look like up and down. Okay. Now, as we progress through scanning, we're at the point now where when you do that same scan, and I produce, let's say, 400 slices through your body, this is the axial cut, instantly it creates a coronal section, and it presents me with your body standing, looking at you from the front.
Boy,
and also a sagittal set of cuts, which slices you top to bottom from the side. So I can look at you crossways, frontways, and sideways, and then besides being able to do that, you can actually take each of those images and crosshair them, so that if I'm looking at something on the cross section here, I look on this screen and I know where it is, looking at you front to back or side to side, and it just
my
puts everything right where you need it to be.
The computer is really doing, it's basically putting together the 3D model, it sounds
They are
like.
3D. And then if you really want to get fancy, it will produce a 3D image. For instance, one of the hardest things to read might not seem that way, but ribs. Rib films are difficult. And the reason they're difficult is, if you think about it, they're attached to your spine, they come around your body, and join in front of the sternum. So what image, and then they're never on the same plane. You know, you take a breath and they're tipped this way. So you say to you, what image, how are you going to see these? Well, with the latest and greatest in CTs, the tech can instantly produce a three-dimensional image, okay? The three-dimensional image allows you to just take the rib cage, totally, just like you had a skeleton in your hand, and rotate it front to back, around the sides. You can see other detail. You can see where there are rib fractures or whether there's any significant pathology. The detail is mind-boggling.
I'll be darned. And that's kind of where I was going with the fact that you've been doing this so long. You've gotten to see from, say, the Polaroid to now the super deluxe digital camera.
This is true. And in fact, some of the procedures that we did 40 years ago would actually be scary.
Oh, really?
When I want to have a humorous conversation at a meeting, I'll say, well, you know, we could have done a pneumoencephalogram, looking at a brain, say, you know, what's a pneumoencephalogram? Well, we used to take a patient, we had a spinning chair. You would do a lumbar puncture, which you're probably familiar with the term. We would had him sitting, we would put air in the spinal canal instead of fluid, okay? And of course, when they're sitting, the air rises and it would go up to the brain. And then what we would do is we would spin the chair while we were taking an x-ray. And that would allow us to blur out everything except the images in the midline where the air was, so that we could decide whether there was a problem in the brain. I mean, those were barbaric.
I was going to say, that sounds a little barbaric, and that was only 30 or 40 years ago.
But the difference is now, you just do a CT scan, you have all that information.
And the computer's got all that
the computer's got it. The MRI, of course, was an even further advance in that MRIs are multiplanar. You don't have to reconstruct images. An MRI actually looks at you in 3 planes.
Oh.
It takes horizontal slices, it takes coronal, and it takes sagittal.
Oh, I see.
So it can look at you in all these different planes without reconstructing. It does it all as a primary information. Probably the biggest difference to the layperson in why you would use one as opposed to the other is that MRI, because of the physics of how it's done, is not good for looking at bone. Bone on an MRI is just a black hole.
Oh, really? It doesn't pick up the
No,
density, or the density
is too dense.
It is too dense.
It's too dense, and because it's based on radio frequency shaking up the hydrogen atoms in cells, it doesn't happen in compact bone, and so you don't see it. So CT scan still holds sway for anything that's skeletal, and MRI does really everything except skeletal.
I see.
I mean, you know where the bones are because you can see the void, but you can't really see the pathology.
Can't really tell. And if you're looking for something, say cancer, you're usually not looking at the bones, right?
Exactly. So what you see, and I need to clarify even a little bit more, you can see bone marrow.
Oh, okay.
Okay. So whereas you won't see the outline of the bone, let's take a femur, you're looking for you don't see it, but you do see the marrow. And so if there's metastatic disease or tumors you're looking for, or things within, or if there is a fracture is going to cause edema in the marrow, and you know from looking at these changes that there's a fracture. You don't see it as well. Then you go back and you either do a CT or plain film, and you just find the fracture.
So that's why sometimes you'll have that one kind of scan procedure, and then 3 hours later,
you may have the second.
Perhaps you come in, or it's maybe the ER physician and says, well, we've got to do one of these because now they think they know what's going on.
That decision's made by me usually.
Oh, okay.
Okay. So, and for instance, if a person comes in with a stroke, okay, if you have a hemorrhage, CT is the best study. Okay, it'll show a hemorrhage immediately. If you have a non-hemorrhagic stroke, either from a thrombus or an embolus, the CT scan can look absolutely normal.
Oh,
you can take that same patient 5 minutes later and put him on an MRI scanner, and because it is so sensitive to water density and subtleties, you can see a non-hemorrhagic stroke instantly.
I see.
Okay, so there's a balance between the two, and sometimes folks wonder why am I getting both of these things done?
Yeah.
And really, there are clearly differentiated reasons for why you do it. So.
Do we? And I think I know the answer to this, but I'll ask, do we do any kind of radiation as treatment, for cancer at Mark Twain?
We do not.
We don't. I didn't think so, but I wasn't sure.
No, that requires, when I trained, therapy was very simple. We had a simple cobalt machine that had a big radioactive source. You open up the thing and it zapped the patient, and really was crude.
Yeah.
The units now are like 20 million electron volt machines. They are just, and they can pinpoint, they can treat something that's maybe 5 millimeters in size. I mean, it's advanced to that level. That's a whole separate field, and the equipment is very
incredibly expensive. Yeah.
Right. And you need to have a large volume, and that's why you see, therapy centers they're not in every hospital.
Sure. What fascinates you the most about the work you do? I mean, is every case, interesting because it's a different person and maybe you're looking at something different, or
in all honesty,
is there something that you really, this one's a mystery, this is a fun one kind of thing?
Well, unfortunately.
And I don't want to sound macabre with it because I know we're dealing with people's health, and I don't want you to sound like a mortician, but at the same time.
You never want to be an interesting case.
Yeah, okay? I can understand
Bottom
that.
line, so for me, interesting case means it's a challenge and there's something that's really hard to figure, and that it usually doesn't spell well for the patient.
For the patient,
but for the most part, I like radiology for a simple reason. You have to know everybody's business. I mean, there's hardly a patient that comes into the hospital, whether through the ER or any other admission, that doesn't end up in X-ray for something.
Yeah.
Whether it's a simple chest X-ray, or whether it's an extremity, whether
do
it's
they
a
still
CT.
do that chest X-ray for everyone that's admitted to the hospital?
No.
Okay, I wasn't sure.
Those things have changed, because there were times when it just didn't make any sense. But if you are admitted and you're thinking going to surgery, it's a good idea to have a chest X-ray.
Yeah.
Any pulmonary things, and because we have an elderly population, I would say the majority of patients do get a chest X-ray. But for the most part, to go back to your original question, to me, you have to know everybody's business. You know, I have to know what the orthopedists are doing and the surgeons are doing and the gynecologists are doing and the pediatricians and the cardiology. You have to know all their business, because if you're going to do studies on the organs that they concentrate on, I have to be given. They want answers.
Yeah.
And they expect me to give them to them. You know, and so, you know, they like to think that they, you know, it's collaborative, and there are things that within their specialties that I'm sure they're advanced over where I am with their specific things. However, it's very interesting because my day, you know, on a day like today, I mean, I'm doing MRIs and CTs and nuclear medicine and ultrasounds and plain films. There's an endless variety, and everybody's different.
Sure.
We were making this. Someone asked me today, is how often do you think you can recognize the inside of someone's body by a CT scan? I said, never.
Yeah, because you might scan the same person tomorrow, and it'll look a
it
little
already
different.
looks different. Right?
Yeah,
you know, I mean, it really does. I mean, unless there's pathology, and then you recognize that's there. But for the most part, you know, we are really built the same but different. You know,
perfect, just like on the outside.
Just like on the outside, exactly. Yeah.
What do you see as, you know, you talked about the computer kind of getting us to almost a max with some of this. Where does diagnostic imaging kind of go from here? Are we getting to the point, you know, where Dr. McCoy is going to wave the magic wand over us and that'll tell us what's going on inside?
Are we going to get to the space like Star Wars, where you just step into that little machine and the bubbles go up and you have everything? You know, we're getting close. You know, the strange thing is that, except for the three-dimensional aspect of it, you know, this is what CT and MRI does. I mean, in a very rapid response. Now, they've developed computer programs that spot, you know, irregularities or things that really say this is an abnormal tissue or this shouldn't be there or whatever. Like, for instance, with mammography, every mammogram we do, we also run through a computer. And a computer says, you know, it looks for differential densities and looks for things that you might not look on a plain film like it was significant, but because the computer sees depth, it'll say, you know, check this out or check that out. So I would say we are very close to being probably as far as you're going to get. Well, I shouldn't say that. I thought that years ago.
Yeah.
Right? and then the next thing you know, they're out. We have a 128 slice scanner, which is really state of the art. Okay. However, if you go to a research center, they're now using 256 slices and 512 slices, and actually it's sort of a misnomer because they're not really slicing you up like that. What they're doing is saying, we can take your scan and we can use a computer and dissect you as if we took scans that were like a quarter of a millimeter apart.
So if they really needed to get into that kind of detail.
You know, like right now, I can slice you at 1 centimeter thicknesses, right, for your whole body. And if I really want to get down to the nitty-gritty, I can get slices that are probably 4 millimeters thick.
Wow.
And so, you know, there's very little escapes that kind of a beam. When you take those kind of slices, put them back together and look at an organ, your chances of missing something are pretty slim. So it's,
I bet. Does on looking at an X-ray, now I know looking at bones on an X-ray, now I have to be really careful which term I'm using. X-ray. You're going to see the break relatively easily, yes?
Most of the time.
So then in these scans, I've seen scans. I mean, I've had kidney stones, and I can see it. And okay, yeah, that I can. Now that you've pointed it out, I can see that looks like a blockage because it looks like there's a knot of something there. But for us lay people, we're not going to know what we're looking at.
Not for the most part.
So is that as the computer has come along, and you know, do you get a magic map that says here's what this image is going to look like, or do you?
I doubt that. You know, if people are interesting, there are folks that. You know, if you do a procedure, their eyes are glued to the screen, or they want to stop by and they want to go over everything. They want to see what it looks like. I would say still a majority of people are happy to know that either they're okay or they're not, and they don't really want to see all the fine detail in between. So is it going to get to the point where you can just, you know, stop at the local drugstore and step into a booth and get a scan?
And it'll tell you you have,
I don't think that's going to happen.
Not quite,
but you never know.
Sure.
You know, we live in funny times.
Yeah, we do, and you never know where somebody's brain is going to take that technology. That's what I'm noticing. And because there's so many individuals, you know, everybody wants something different. Now, something we do here on Mondo Calaveras, Dr. Griffin, and since you've been in the county for quite some time, I ask a few questions of everyone who's here just to kind of get their feel for the county. What's your favorite place in Calaveras County to visit?
Favorite place to visit? Murphy's.
Murphy's. Kind of just everything about
Just everything
it?
about it. You know,
yeah.
my wife loves to wander the streets and look around and watch the people. Weekends, you know, it attracts a very eclectic crowd, and it's probably the most activity.
Yeah, yeah.
Other than that, my favorite place is home. I have an incredible home with an incredible view, and I can see what I need to see.
And he grows wine grapes, just so you folks know. Who makes your wine? What do you make on your own label? Or?
No, we don't.
No.
We strictly sell the grapes to some folks in Napa and to a couple of the winemakers in town.
I'll be darned. That's what a lot of people don't realize is that a lot of grapes from up here in the foothills end up in Napa.
Yeah, I'm not, you know, I'm not really sure how many do, but when we put our grapes in, we put in unusual varietals, and so for that reason, some of them have ended up over in Napa.
As long as you get a few bottles of the final product, right?
Oh, well, of course. There's always a case of wine that should come along with the check for the grapes.
That's right. Well, I like how you think. Not a couple of bottles, a case.
A case, it's hard to ship a couple of bottles.
That's true. Where's your favorite place to eat in the county?
Well, we probably split our time between grounds and camps.
Grounds and camps, yeah. Camps does even a great lunch. Actually, both places do.
They do.
But and actually, for me, camps on Mother's Day or Father's Day, they do the best Sunday brunch on planet Earth. They have an Eggs Benedict that'll knock your socks off.
I've been a member over there since the day they opened. So.
Have you? Oh, great. And then finally, where is the first place you'd take visitors, newcomers to the county that are visiting you? Murphy's for dinner, but
for the most part, you know. But from the scenic standpoint, it's big trees.
Yeah,
basically, yeah. Really, you know, really pretty. And you know, the thing about it is, the problem is the county is so beautiful. There are so many areas that you can drive to that you can't pick a place. I can drive down Pool Station Road where I live. Excuse me, and on a good day, the scenery is beautiful.
Well, that's my favorite road in the county, but I'll admit you probably don't recognize the color of my car as I go by because I love to drive that road with a lead foot. But it's a beautiful county.
I've done the same. It is.
It is.
It's a great place to live.
Yep.
You know, it's what can I say?
What we do. Well, Dr. William Griffin from Mark Twain Medical Center, thank you so much for joining us today. It's been a pleasure talking about all this with you.
It's been a pleasure to be here.
I appreciate it very much. And ladies and gentlemen, keep your bones healthy. I'm Mike Taylor. Thanks for joining us on Mondo Calaveras. Enjoy.